That's your opinion as well?
Yes, I quite agree with that. And as we said, mammography, the signs of cancer of the invasive lobular carcinoma are usually very subtle, increased, like the case we saw, just increase in density, asymmetry, a spiculated mass, and the incidence of microcalcifications is far less than with the invasive duct carcinoma, ranging about 16%. And of course, the lack of desmoplastic reaction also pose another difficulty for mammography, and that's why the sensitivity and the accuracy of mammography in detecting these lobular cancers are really not so high. On the contrary, the ultrasound is more popular and more accurate in the detection, like, again, the case that we saw where there is a lesion. Now, what's coming into now the role of the MRI, I don't know if this is the time to talk about the role of the MRI in the next. But yes, I quite agree with all what you just said.
Okay.
Thank you.
So the patient preferred to go for mastectomy. Pathology showed the classical infiltrating lobular cancer with a diameter of 3.1 centimeters, node negative luminal A disease, with multiple foci of infiltrating lobular cancer and mixed duct and lobular cancer, which were never shown in the done. We did not have a MRI for this case. Importantly, the lesion was 1.3 in preoperative ultrasound. So we have discrepancy between the surgical dimension, which is the real dimension, definitely, and the imaging dimension. I need the opinion of the surgeon, of course.
Is there a discrepancy in the clinical dimension, which is the thickening of the tissue, and the pathologic finding? That is a real issue. And the other issue that I would like to raise, why a mastectomy? Why not a lumpectomy? Why not attempt a lumpectomy in this patient? It still remains 3.1 centimeter. And the third issue, why an axillary node dissection? Why not a sentinel node biopsy?
That's what happened. I'm not saying that it's the state-of-the-art management. This was 5 years ago. And again, we're just discussing a file of a patient. Okay. We're trying to pointing out that the sonographic diameter was far less than what we really saw in the pathologist.
So as a surgeon, I always, when I want to operate, I have to examine the patient clinically. And sometimes particularly in invasive lobular carcinoma, we know that the mammography and the sonography may not reflect the extent of the disease. And this is where the surgeon would rely on their clinical examination preoperatively and decide whether this patient is a candidate for breast preservation or not. And they will have to excise all the area that is thickened and feels abnormal to them.
Again, my question for our three pathologists, do you need to add on that? Any of you?
Definitely, and that is what we discussed before. The importance of lobular morphology is that when we have this diagnosis, we know that our gross evaluation is not going to be as accurate as having a big, well-defined mass. So when we are evaluating the tumor size and when we are evaluating the margins of a segmental resection or total mastectomy, we have to be extremely careful, because sometimes when you feel it, just like examining the patient in the clinic, when we are examining the specimen, we may not appreciate the size of the tumor. So grossly, we may think it's a 1.5 centimeter, 1.3 centimeter tumor, but when we do histologic evaluation, there is a lot more extensive tumor. So that is where the importance of invasive lobular morphology comes in. It's not what you call it, Indian or single-cell infiltration pattern. So it's important to carefully, you pay a lot more attention all the areas of thickening. You said like this, in this case, there were multiple additional foci. So how these foci are related to the main tumor. Are they all in continuity, or they are truly separate multiple foci? And
are
then
you in a position always to know that, whether they are in continuity or independent foci?
It is important because for
it is important, of course, but I mean from the pathological standpoint, are you always in a position to acknowledge whether it is in continuity or it is independent to size?
Of course, that's the most important thing for the pathologic staging of the tumor. If that entire area is 5-6 centimeter and it is all a continuous tumor, then it's going to be a T3 lesions, as opposed to now multiple foci. The largest focus is, I forgot how big it was, 1.5. It's going to be.
So the pathologist is in a position to know whether it is in direct continuity or it is independent of size.
Of course, if you do a careful examination, gross evaluation, you will be able to tell that. So that's where the importance of that single cell infiltration comes in.
Okay. Do we have any further?
Well, fundamentally, the discrepancy between clinical measurement, imaging, and actual pathology has always exists there because of a variety of reasons. And another component that we have to keep in mind is the fact that when a cancer develops, around the cancer, there are not only a lot of desmoplastic reaction, but there are going to be some proliferative lesions or other fibrocystic change that they may present as an additional thickening or presentation clinically by imaging, that when we examine the case and we identified cancer, the measurement is always the measurement of invasive cancer and not necessarily the desmoplastic or other non-cancerous tissue that they may present themselves as a continuation of the same kind of thickening and mass or non-thickening or not mass production. So that discrepancy is always going to be there. And the only way that we can understand or we can minimize that is try to pay attention to a accurate and consistent way of measuring, both clinically, by imaging, as well as by pathologic examination, so that what we report as the measurement of the tumor by pathology is exactly the size where the invasive cancer is and nothing else.
Okay, thank you. So, the take-home messages from the first case is lobular cancer is linked to combined hormone replacement therapy use and Western lifestyle of parity. E-Catherine is a hallmark in the pathogenesis of the disease, being diffuse invasiveness, infiltrating lobular cancer induces little desmoplastic reaction, and this explains the difficulty to diagnose invasive lobular cancer early because of its less clinically palpable and less mammographically detectable. So, invading lobular cancer as well tends to be diagnosed later. Do we have any? Yeah, you wish to comment?
I think the most important message that we should get from this case is that when you have a clinically suspicious mass, a negative FNA does not mean that there is no cancer. So that FNA should have been actually a non-diagnostic FNA. So a year ago, before the core biopsy, I think there should have been an additional biopsy done.
Definitely.
So that should be the number one take-home message.
The wrong decision for finding the aspirin. But if you said so now, should we forget about FNA altogether in the diagnosis of pathology lumps? I mean, should we consider this as not to be done, as a firm conclusion?
As I said, FNA, when you are performing FNA, it needs to correlate with clinical evaluation and imaging findings. In this case, there was a discrepancy. So instead of saying that FNA was negative, it should have been said it was not adequate.
The clinical findings was not very strong, and the mammography was, again, not very much informative, by the way.
But there was a thickening, so there should have been a reason for that, and that FNA was not. It did not show malignancy, but it doesn't mean that it was a negative finding.
So, if I may interject and say, if you have a thickening, don't evaluate it by an FNA. Evaluate it by a corneal biopsy. The use of an FNA for palpable mass is still legitimate and still doable.
So, thank you. That's very much of a surgical take-home message, which is quite fine for me. Yes, from the radiologist standpoint.
Yes, I think what we lacked in the first case is the ultrasound. Ultrasound is very important as a diagnostic tool, especially that the woman came complaining of a thickening of the skin and the mammography was equivocal. I think this was part for the ultrasound, because ultrasound, especially in lobular cancer, is more sensitive than mammography. I think that's make things more clear about that.
Okay.
Thank you.
So let's go for the second case. This time she's a little bit younger, 54 years, postmenopausal woman presented with ill-defined mass in the lower outer quadrant of the left breast of 4-month duration, no palpable axillary or supraclavicular lymph node. Mammography was like this. I need the radiology opinion.
Mammography shows, it's a mediolateral view, shows ill-defined outline, irregular, minimally irregular outline with few microcalcification, dense mass lesion. I would classify it as BI-RADS 4C. It's highly suspicious mass.
Okay.
I cannot see any lymph nodes or associated findings.
BI-RADS C, then it's highly suspicious lesion. So, and that's the ultrasound.
We have a solid hypoechoic mass with angular margins and ductal extension with posterior acoustic shadowing. It's also very highly suspicious, maybe by BI-RADS 5.
Okay. We don't really grasp what's meant by focal shadowing. What do you mean by that?
Focal posterior acoustic shadowing, meaning high blackening behind the tumor. It's a sign of subtle microcalcification within the tumor.
It's a sign of?
Microcalcification within the tumor.
So for us, it's a sign of malignancy. You mean?
Yes, sign of malignancy.
Thank you. So, through cut needle biopsy, again infiltrating lobular cancer, again luminal A phenotype as the prior one. Are these data enough for, my question is for the surgeon, of course, for you to take a decision of breast having surgery, or you need more breast imaging workup? Yeah.
You're asking me as the surgeon?
Yeah.
The answer is no. I would not do an MRI. I will proceed with a lumpectomy, a sentinel node biopsy. If I think, because you did not give me the information about the size of the breast of the patient, the size of the breast of the patient. If I think the tumor is too big for the breast, then I may consider some neoadjuvant therapy. But if I think the way it is appearing to me that the breast is acceptable size and the tumor is 3 centimeter based on the mammographic and sonographic finding and my clinical finding, I would proceed with a lumpectomy and sentinel node biopsy. I would not do an MRI at this time.
Okay. Of course, the radiologist will vote for MRI. I'll do MRI for you.
Before the MRI, we can start with the needle biopsy, core needle biopsy. Just
done already. That's the needle biopsy. Now,
okay, so just for the audience.
What do we need for? That's why my question was for the surgeon, whether you need further insights of the disease. And actually, we went for MRI. A very important take-home message, not on the slide, is that this kind of differences in opinion between the members of the tumor board is very healthy, and that's very typical in the tumor board, by the way. So don't be offended that we have different views. Okay, that's the MRI. It's courtesy for the radiologist. Okay. I need your opinion, Asif, and then your opinion, Mahmoud.
You asked, yes.
Yeah.
So what
now,
was
after the MRI?
Okay, well, this is the problem of doing the MRI. Now you have an MRI, and you look at this, and you're definitely going to say, probably this patient is going to need mastectomy if you want to go without any neoadjuvant therapy. And the MRI in lobular carcinoma, there's a lot of studies that have done. The problem with most of these studies are retrospective studies with very small numbers. The only study that has a very large number on invasive lobular carcinoma is the review by Husami. And the review by Hussaimi was published in the Annals of Surgery in 2013. It's a meta-analysis with 700 cases of invasive lobular carcinoma. It did show that there is a decrease in incidence of re-excision with MRI when you do it for invasive lobular. However, from the get-go, before you do the lumpectomy, many of the patients, much more than those who did not have an MRI, had a mastectomy, and perhaps that's why there's an decrease in re-excision rate. Having said that, that decrease in re-excision rate did not reach statistical significance. So if you're going to show one paper or two paper or three paper, unfortunately, they're all retrospective analysis, and I think still the jury is not out yet. Now, the real question that I want to ask most of the people, do you think when we do a lumpectomy, we're completely taking the disease out of the breast? The answer is no. We have data that has shown that. We are minimizing the amount of the disease in the breast. And then if you have a positive margin, then you'll go back and you re-excise. Now, the only thing that MRI may help you is that you may consider giving neoadjuvant treatment. Having said that, giving neoadjuvant treatment, neoadjuvant chemotherapy may not be effective in invasive lobular carcinoma. So I'm trying to tell you the reason why I'm not doing the MRI. So if I want to do something, and my center would give neoadjuvant hormonal treatment, then that may be an option, particularly when the case is borderline.
Other important test in the workup of this patient should be evaluation of the regional lymph nodes. This is a 3.4 centimeter invasive lobular carcinoma. So her chance of having a positive axillary lymph node is significantly high. So the lymph nodes should be evaluated prior to surgery.
Yeah, definitely. That's part of the static workup. Yes, please.
And it's one of the cases where we are allowed to do immunohistochemistry on the lymph node, because with lobular carcinoma, sometimes to see the invasion, it's very difficult in the lymph node. Yeah. So we can sometimes do that.
Okay. Our radiologist, and don't be offended because MRI is not recommended by the surgeon. Okay.
Yes, well, I have to argue a little bit because we have many studies were done by men. It was a meta-analysis, and it found MRI is not just done for the sake of diagnosing a lobular carcinoma, but it's also to detect the multifocality and multicentricity, and above all, the other breast lesions that might have been hidden from not seen by mammography or ultrasound. And in other studies and research they found that the use of the MRI, the application of MRI, could affect the management decisions in 50% of the cases, and affected also the surgical decision in 28% of cases. And that's called into the studies in the literature.
So we have this statement. Do you agree on this statement, the surgeon and the radiologist? Statement number 2. If infiltrating lobular cancer, like our case, is confirmed pathologically, this patient is confirmed pathologically, and breast conservation is favored, MRI should be considered to assess tumor extent and to get additional information about multifocality and multicentricity. The term should is too harsh, as you can see.
I would
should
say
we keep this?
I would not say should. I would say maybe considered.
Okay.
Definitely, it should not be. Individualize the case, and you see how do you feel, the extent of the disease clinically, and what you see mammographically and radiologically. And if you think the patient is borderline breast preservation, then you may consider an MRI. If you're considering neoadjuvant therapy, definitely I would do an MRI because it's one of the best tools to detect response. But definitely I do not order MRI on every patient with invasive lobular carcinoma.
So it's not should, that's from the surgeon. From the radiologist, Ashraf, would you comment on the last statement? This information should be evaluated, I mean the information obtained by MRI should be evaluated carefully, and breast conservation should not be given up solely on the sole basis of additional lesions detected by MRI.
Sure, the second part, yes, sure, I agree with that. But also I would like to add about the use of the MRI I know that the argument here is that because it's not specific, I mean, it's many enhancing lesions that surgeons, I know that this put us in long debates with the surgeons and the oncologists about the specificity of breast in lobular or otherwise, but still the application is very important in cases with invasive lobular carcinoma, as I said, for the detection of multicentricity and multifocality, and the other breast as well as if these patients are going to receive neoadjuvant chemotherapy as a means for follow-up of these cases.
Let me just make a comment. One of the things about the studies looking at MRI and invasive lobular, they all show and talk about, those that are retrospective, about multifocality. But none of this, very few of the study talk about the oversizing of the lesion, where it is falsely large, and then you end up doing a mastectomy unnecessarily. And also, and from pathologic studies, in invasive lobular carcinoma, 50% of the time, the MRI does not give you the accurate size of the tumor. So you have to take this data into consideration when you're thinking about doing a test that will not change the survival, will not change the local recurrence, and will delay the care of the patient and will increase the cost of care, particularly in countries where there's a very limited resources of care.
So now we're again about probably the guidelines for MRI imaging in lobular cancer needs to be more emphasized in a separate report. We start to make use of the presence of the oncologist, the non-surgical oncologist. What kind of surgery you wish to do for this woman? Modified radical mastectomy, breast conservative surgery, or this is a relatively large invasive lobular cancer. If breast conservative surgery to be considered, then a better idea to try to downsize the lesion. And who wishes to start from the oncologist? Fadi, probably? Yeah, you.
I think we have to discuss with the patient what she wants, and she is a perfectly good candidate for a conserving management. Now the size, and I agree with Mahmoud that MRI is actually giving us more trouble most of the time than help, unfortunately, and I would not take this information very strongly in my algorithm of management, and we discuss with the patient what she wants.
Yeah. So the trouble of MRI, would it better to have it before surgery or after surgery? Because actually we shouldn't be very harsh on preoperative imaging to give us more insights, because we need the insights, definitely. Let's have a look. Do you agree on neoadjuvant treatment for this patient? Another formulation of the question. Dr. Fadi, you wish to have neoadjuvant treatment? You will vote for neoadjuvant treatment? Irrespective to what kind of treatment?
No, I think if this patient is a candidate for upfront conserving management, I don't see a compelling reason to use neoadjuvant therapy.
Great.
It's an option that is valid, but it's not. There is no compelling reason to go this way.
Dr. Alper.
I think it's an option we should discuss with the patient. It's 3.5 centimeters. Maybe the patient will go on in a mastectomy, and we will discuss with the patient.
Okay. Joseph.
Yes, of course we need to ask the patient if she wants mastectomy or not. This is the first step.
Yeah.
The second one, let's suppose that the patient wants to have breast conservative surgery. When we have to discuss with the surgeon about the possibilities.
Yeah,
because if the surgeon says yes, I will not consider any neoadjuvant option. If the surgeon says no, then even if we can discuss about endocrine neoadjuvant treatment, the most difficult position will be if you initiate with endocrine treatment and you operate then the patient, and let's suppose that you have 5 positive lymph nodes in the axilla. When you will go back and discuss adjuvant chemotherapy after neoadjuvant and endocrine treatment, it's totally crazy. So my consideration is not to offer the possibility of neoadjuvant approach systematically, and strongly discuss it only if the patient in front of you clearly wants to have conservative surgery.
Thank you. From the technical standpoint, the surgeon, I'm sorry, do you go straight forward for doing breast-saving surgery in this case?
Do conserving surgery?
Yeah, I have mammography, sonography, and
well,
MRI.
you know, this is why I don't want to get the MRI because it's going to confuse me. And I may end up taking a huge amount of tissue and end up having, oh, great, we took a huge amount of tissue, but there was no disease in that tissue. So this is why I didn't want the MRI.
But
now you have the MRI in.
We may have a disease as well.
Just
it's
hang
not
on.
all the time negative.
Let me finish.
Yeah.
Now you have the MRI. So if I really want to consider conservative surgery, I would like to do 2 biopsies with clip placed in this patient. The 2 biopsies at the extreme of the extent of the disease and prove that this is disease. If this turns out to be truly disease at one point and at the other point, then the patient has clearly multicentric disease, and the role of breast conservation in multicentric disease becomes probably debatable, seriously debatable. Then I will proceed with a mastectomy. But unless I have direct evidence that the MRI finding is pathologically proven to be malignant, I would not proceed with mastectomy on this patient. So now that I have the MRI here in front of me, my next step is, before I do the surgery, please repeat the biopsy and do the 2 biopsies, one from each end. And if these turn out to be malignant,
Here
then
and there.
correct. And then that would define the extent of the disease, and then we'll proceed with a mastectomy.
How doable is this, the radiologist, for the radiologist? Is it doable easily for you?
It's easy,
the
but
surgeon tells you that I need to have a biopsy from the extremes of edges of the lesion.
it's not a problem. It's a good idea to take a biopsy at outside the edges in order to exclude the extension of the tumor outside the image evidence. I don't mind, but why not do MRI? MRI is proved the most sensitive method for diagnosis of lobular carcinoma. And knowing that 11% of lobular carcinoma do not show in mammography and ultrasound, so we can expect multiple.
Actually, it showed. We are applying on this case.
Other foci may not show. So I think preoperative MRI is a necessity when having lobular carcinoma at pathology, diagnosis at pathology. It is even more sensitive than PET-CT in diagnosis of lobular carcinoma.
Yeah,
so I don't.
It's the oversensitivity probably. So again, my message for everybody in the room: this is a very usual, healthy discussion for tumor board. So that's normal. Okay. Now, Mark, you wish to give the adjuvant treatment?
For this patient, she's borderline to do conservative surgery. Okay.
Yeah.
And I think it's better to do, in this case, mastectomy to be sure of the positivity or not in the lymph nodes. Because I agree with Joseph, the most important, if this patient has 3 or 4 lymph nodes, the treatment will be first the chemotherapy and hormonotherapy after.
Okay, thank you. Again, I'm sorry, we're using you over using you. Do you agree on this statement? Is breast conservative surgery equal to modified radical mastectomy in lobular cancer? Do you agree on this? Is it equal?
Absolutely. If you achieve negative margin, absolutely. No question in my mind.
You agree on the statement?
Yeah.
Generally, lobular carcinoma is treated more often with mastectomy rather than more than duct carcinoma. But this is attributed in part, at least, to the advanced T-stage encounter in patients with lobular cancer. Still, the inherent difficulty to define tumor margins owing to the infiltrative growth pattern and multicentricity of the disease may